Thank you so much to all the organizers for this tremendous opportunity to share pediatric perspectives on pain with our huge international audience. This talk is entitled No Pain, So Many Gains. It probably should be minimizing pain, so many gains, but that just wasn't quite as catchy, so I went with no pain. But I mentioned that to acknowledge that we can't always make all pain go away, but we can certainly make efforts to improve that. Before I delve right into it, I'd like to acknowledge that I'm delivering this session from my home, which is located on Treaty 6 territory, which is the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the Métis. And I'd like to acknowledge their footsteps, which have marked these lands for generations. I have no financial disclosures or conflicts of interest to declare. I do not have any corporate or pharmaceutical funding, as I will be discussing medications and various therapies. I do have Tri-Council funding for my research, which is peer-reviewed. So what I'd like to focus on a little bit today is why childhood, in quotation marks, temporary pain matters. And I'll use acute presenting pain or related to illness or injury pain, as well as procedural pain related to minor or brief procedural medical procedures that we need to do in the course of investigating illness in children as exemplars of why this pain matters. And then take some time to reflect as a virtual group on what we can do about it. Untreated and poorly managed pain in childhood means a lot of things. And I think Katie Caldwell, Dr. Burney, Dr. Knoll have all really done a tremendous job of explaining to us why it matters. But if I had to summarize it with apologies to the depth that actually this involves, I can tell you that it means longer healing times. It means longer hospital stays, more complications when you are hospitalized, needle phobia in the long term with procedural pain that is not addressed, future care avoidance. So sometimes these children who have had negative pain experiences go on to become adults who avoid the healthcare machine or the healthcare community just to avoid pain because they don't trust their bodies as much. Brain wiring and EEG changes in younger children, and even IQ changes where IQ measurements drop in children who have had repeated poorly managed pain. On the flip side, what does well-managed pain mean? It means faster post-op mobilization. So children will get out of bed more quickly and will recover more quickly. We know all bodily functions work better when we're moving. Less procedures overall that they might need to have, because if we get it right the first time, we don't have to keep trying for that lumbar puncture or keep trying for that IV. Shorter overall procedure time, better patient flow, which coming from the emergency world is a very important factor for us when we have large volumes waiting to be seen, and greater family and healthcare provider satisfaction. And of course, the families are core in their satisfaction. We want them to have a positive experience, but I would be remiss if I didn't mention the healthcare part as well, especially in these current times where our healthcare providers are feeling so crushed from so many different for so many different reasons that increasing their satisfaction with their job experience and their patient interactions can make a world of difference. So first, I'll talk a little bit about acute pain. And unfortunately, we don't have very great beginnings. When we go back into as recently as the 80s, our colleagues from the UK, led by Dr. Sunny Anand, did one of the earliest studies where his team looked at infants having cardiac surgery. So we can all probably agree that that would be invasive and painful. And at this time, babies were receiving paralysis and inhaled anesthesia, but no pain medications. And he took these babies and divided them into half to receiving the nitrous oxide and paralytic, and the other half received those two as well, but also added fentanyl. And no shock to any of us now in 2020, the babies who received the fentanyl showed less signs of stress in terms of cortisol and other stress hormone measurements when they did blood tests. And they also recovered faster and had less critical postoperative complications and incidences. So he really showed us one of the first examples where he spelled out that they do feel pain and they do better when we treat pain. Dr. Schechter and colleagues in Connecticut around the same time looked at 3 very painful conditions, ones that we would all say were uncomfortable, 2 of which were appendicitis and femur fractures, which is, femurs being the biggest bone in the body, breaking it is going to be significant. And he showed that youth and pediatric patients, so under 18, were receiving analgesia at half the rate of adults for the same conditions. And the younger you got, the less likely you were to receive pain. So we were unfortunately ageist. And I would love to say in 2020 that this is completely gone, but that is not actually the case. So this is where we started from, and we've made tremendous strides, but there's still a lot of work to be done. Sometimes when I'm working in the pediatric emergency department, I wonder if it's not me, it's them, because I've heard this from colleagues and I've thought it myself as well. I've offered and they said no. So these measurements, these studies we do measuring how much analgesia is given is not really fair because it's not capturing the nose. So led by colleagues in London, Ontario, we did a 2-center study looking at almost 750 children who presented to the emergency department with a painful condition. And again, that same number, about half, in this case 55%, were offered analgesia by the team. But we went another step and we said, we checked, and if it was offered, 91% accepted. So if we ask, they will accept for painful conditions. And that was a really important messaging for me to consolidate the idea that it's not me, it's them. No, in short, no, it is us. The onus is on us as the healthcare providers to offer it. So let's look at appendicitis as an exemplar of fairly universally accepted as a painful condition. So appendicitis is almost universally painful. The pain is described as moderate to severe. So this was a 12 emergency department study across Canada looking at over 600 cases of appendicitis. And to put this into context, there are 16 emergency departments across the country. So this is almost all of them. And this is a recent study, 2016. Of the 600 plus patients, 40% got no analgesia in the emergency department. Of those who did receive something, 43% received IV morphine. And the median time to analgesia was greater than 3 hours. So as a parent, and as a parent of a child who's had appendicitis, the idea that we already knew they were in terrible pain. We usually are suffering with this at home as a family for a number of days before we even seek care. And then to have waited another 3 hours after we'd crossed that threshold to receive pain is quite disheartening. Even more disturbing was that the first dose of analgesia in those who received it, in the half that did get something, 4 out of 10 was after ultrasound, and a further 4 out of 10 was after the surgeon saw them. So this gave me great pause. Why aren't we trusting them at the gate? Why are we not responding at the gate? Why are we waiting until after our eyes see an ultrasound report to say, oh, then it must be worthy of analgesia? That to me says we have some work to do. And I'd be remiss if I didn't mention the racial disparities in pain treatment in children overall. And I'll use appendicitis as an exemplar again. Now, this study is American, and that's not because Canadians are doing such a great job. It's because Canadians don't measure it. And that's been a sad realization for me this year as I've been reviewing and researching this topic, is we have some work to do as a nation to rectify this lack of information. So this study looked at almost 1 million children across the United States of America. Again, 53% received nothing. 41% received an opioid, just like they did in Canada. So overall, our neighbors to the south are behaving very similarly to how we are in terms of our clinical practice. But here's the kicker. The children who were white received analgesia at a proportion of about 57%, Black 55%. So we're like, okay, that's not too terrible. But when we got into type of analgesia, you were twice as more likely to receive an opioid if you were white versus if you were Black. Now, I cannot think of, nor have I ever come across any physiologic, anatomic, or race-based reason for why Black children would experience less pain than white children with appendicitis. So that was quite disturbing to me. And when they looked at it in a multivariable analysis, controlling for other things such as ethnicity, age, sex, insurance, pain scores, which is a really important one, because if I was wrong and Black children actually experienced less pain with appendicitis, this would have caught it. Still didn't go where we wanted it to go. The adjusted odds ratio was 0.2 for Black children to receive an opioid, meaning they were 5 times less likely to get opioids, even after we adjusted for things that would influence what you might experience. So we have some work to do in this realm as well. So if we're treating, how do we treat? And this is, I'd love to talk about treatment of acute pain for days, but alas, we can't do that. So I'll briefly present it as thinking about it in threes, always in threes. So the first thing is physical. Whether you are doing a procedure to help a child with a painful condition, or whether they are presenting with their painful condition and you're not doing a procedure at the time, physical measures matter. So this may be as simple as warm blankets. I cannot tell you how many times I'm quite convinced that is the most important thing I've done in my emergency department encounter with a family, is provide them with those deliciously warm blankets from the blanket heating machine, because it provides a sense of comfort in a time that's very uncertain. It can be a younger child being held by their parent. It can be kangaroo care in certain settings, depends on what's going on. Then there's psychological. And the image portrayed is that of virtual reality, so a fairly advanced form of distraction. But there's also things we can do that involve using affirmative language, of validating the child's experience, of speaking the truth to them, of providing them with simple distractions, which may be their own technology that they brought. It could be a book if they're feeling well enough to read. It can be as simple as bubbles, and depends again situationally. But when we miss out on using physical and psychological strategies to start treating pain, we're missing out on some incredibly powerful tools. And then pharmacologic, which we layer on along with the physical and psychological. And I've tried to put together the briefest of summaries of analgesic prescribing principles as I understand them based on the current evidence. And this is a moving target, but I think some of these would be my truths, or these would all be my truths currently in 2020. So ibuprofen or acetaminophen first, if they do not have severe pain, if they have mild, moderate pain. Personally, I always start with ibuprofen, because a lot of the things I treat in the emergency department are acute injury and inflammation. And ibuprofen has that added advantage of anti-inflammatory properties over just analgesic properties. Use age-appropriate dosing. And when I say don't be stingy, what I mean is I always start with the upper limit of the dosing range. So 10 per kilo for ibuprofen, not 5 per kilo. 15 or 20 per kilo for acetaminophen, depending on route, not 10 per kilo. Add an oral opioid if needed, and add is the key word here. Never opioid monotherapy, because we know that when we use non-opioids such as ibuprofen or naproxen, we decrease the need for opioids. It is opioid sparing to do that. And as wonderful as opioid medications can be for managing treatment, they come with more adverse events. There's no way around that. So the more we use non-opioids, we're able to decrease those opioid adverse events and side effects. And not codeine. In 2020, not codeine. Codeine has been shown time and again to barely perform above acetaminophen or ibuprofen. And as of July 31st in Canada, Health Canada has now made a very direct statement stating that we are not to use it in under 18. So really, truly, for our practice, certainly in Canada, codeine should be off the table, with the caveat that if someone has been successfully using it for a chronic condition, that is an exceptional circumstance. But you certainly, in 2020, would not start anybody on codeine for the first time. If there's significant or severe acute pain, more and more now, with our Australian colleagues leading the way, we are thinking about intranasal fentanyl. When you don't have IV access, or if you're in a community setting where obtaining intravenous access in a child is daunting or challenging, this is a route that can help you achieve pain management much more quickly. Master a few agents if this is not your core area of practice. So if you are not an anesthesiologist or a pain specialist, such as myself, master a certain number of agents, be really good with them. And always remember co-therapy. So I have to admit, I have been guilty when I switched to intravenous therapy of forgetting my non-opioid co-therapy in the past. So I'm trying to be very careful about remembering that now. And when it's time to go home, think about a backup plan and sending home with modest amount of doses. So if there's one thing we have learned in the last decade during this opioid crisis that has plagued our country for well over, or at least a decade now, is that we need to be cognizant of how many doses of medications, how many extra pills, if you will, that we're putting out into the community. So gone are the days of writing a prescription for 30 or 60 pills from an emergency department, a dental clinic, an ambulatory clinic, unless there is a very specific reason. For most acute, short-lived conditions, 10 pills or 3 days worth of treatment is plenty. But when you do that, you absolutely must give them a backup plan, because if that is not enough, they need to know who to come back to get more if they are in that subset that is struggling with their pain. So I'll highlight an example of work that SKIP, Solutions for Kids in Pain, which I have the pleasure of being involved with, is doing. And opioids are definitely on our radar nationally. We have joined forces with the Canadian Foundation for Health Improvement and have conducted a series of meetings and engagement of key individuals and organizations and have created an executive summary of evidence to action for opioids and entitled Opioids in Our Children. And for anyone who is interested, this is available bilingually through searching through the SKIP website online. And this was an attempt to bring together resources and individuals to try to have consistent and most evidence-based messaging around how to use opioids for children. We also have joined forces with Children's Healthcare Canada, who is a key player in the SKIP organization. And many years ago, Children's Healthcare Canada had created these wonderful toolkits that I had the pleasure of being involved in, which helped us understand how to treat children's pain, and not only treat, but find resources so that if we wanted to make changes within our own organization, we could grab one of these virtual toolkits that gave us examples of educational resources, policy around different interventions, and patient level educational tools that we could use, and background information, etc., and put them into these toolkits. And SKIP is now working with Children's Healthcare Canada to update and make these even more user-friendly. So this is also a free online resource that is available to anyone around the world. So this is where I'm so thankful to work with SKIP in this reorganization and promoting of these materials, and you'll see more of that in coming months through social media platforms. Going to switch gears for a second now to procedural pain. Procedural pain for healthy children even without a single illness, children will have over 24 painful procedures before they start school, starting with their newborn metabolic screen at birth, which is almost universal across the world, and then including their routine vaccinations. And then if you have any medical conditions, illnesses that require investigation, you can start adding to that. And as you can see by these sweet faces, none of these sweet souls look like they're looking forward to this. And this is the reality of what we see. So how can we make things better for these children? So a little bit more context. If a child is admitted to the hospital, 78% of them will undergo at least one painful procedure in 24 hours. And on average, actually, it was 6 per day. So 6 painful procedures in 24 hours. That's 1 every 4 hours on average. And when this national Canadian study was done, led by Dr. Stevens from Toronto, only 28% had a pain management intervention documented. And IVs, oh, those darn IVs, such a painful thing for children. They describe it in many studies as even more painful than their original reason for coming in. So just imagine. And then again, sometimes I like to hope that maybe the emergency department is more aware or able to address this more efficiently or effectively, because we see so much pain. The current estimates are that up to 80% of emergency department presentations for children are pain related. So this is really our jam. But when we looked at painful procedures, the light gray bar represents, in the graph on the screen, represents no analgesia provided. And this study done in around, which we published around 2014, 60% of urinary catheterizations were done with nothing. Half of IVs or blood work was done without anything. Even over 10% of lumbar punctures, spinal taps, were being done without anything. So that's pretty sobering, because we know we have things that work. So to address this, very recently, beginning of this year, Canadian Pediatric Society published a national position statement led by dear colleague Dr. 𝐒𝐂𝐂𝐑𝐈𝐁𝐄 from Université de Montréal. And this document brought to light a summary of all the things that we knew were solidly evidence-based that could help children having brief diagnostic and therapeutic procedures. So a few examples: managing pain with topical anesthetics. So using this preemptively before skin breaking procedures absolutely works in ages 1 month and above. There's no reason not to be using this. So we now have learned and advocated for this in the position statement. Another example, comfort positioning. So rather than gone are the days where we would hold children down, remove their parents from the room, and do procedures. Now, I'm not ancient, but I can remember at the beginning of my learning and my practice that we were still doing this, and that breaks my heart that I have a living memory of that. We are doing so much better now, but sometimes I still think we have some work to do in terms of engaging our caregivers of the child to be actively involved in the process. And when I look at these pictures on the screen, they actually, as a mother and as a healthcare provider, they bring me peace, because that family is engaged and that child will have so much comfort from the presence of their person. So these are things that are very easily integrated into procedures, but we need to encourage them and we need to teach them. They're not always thought of, and our responsibility as healthcare providers is to engage people to use them, and if we're on the parent side of things, to advocate and ask for them if you feel comfortable, and I would hope you would. Distraction comes in so many forms, so many ways. It can be as exciting and cutting edge and interesting as virtual reality and robots, which is some of the things that I like to experiment with, and we're studying in our hospital right now. But it can also be as simple as conversation, bubbles, decorations on the walls. But all these things can distract a child away from their pain. And as the child gets older, you need to ask them what they want. Some actually prefer to watch, and that's okay too, but we need to give them options. And then we have so many strategies for our sweet babies who, if we neglect their pain needs, we can go on to actually change their EEG brain, like measured brain wiring, and their even their IQ, as I said earlier. So we have a great onus on all of us as healthcare professionals and as parents to advocate for these little ones. And there are so many things we can do, as you can see on the screen, and every one of these is evidence-based with a solid base of evidence behind it to support it. I'll mention that we have this incredible program as an example of something that's been homegrown in Alberta, the medical lead for this incredible initiative being Dr. Jennifer Toole-Friedman from Calgary. And she and her quality improvement team created this incredible initiative called Commitment to Comfort. And they brought it first to their emergency department in Calgary. Then they took it to the 5 or 6 centers within their city that treated children. And then they expanded it to all willing participants across the province, as well as now into our lab services. And the idea is that you have very simple messaging with posters and other visual cues. And as the center of the screen shows a comfort kit, a box with some pretty inexpensive items that help you distract and engage children away from the pain of a procedure. This was combined with practice support documentation, so nurse-initiated pain protocols and evidence to deliver a really simple message around how to make things better for children. And she and her team did an incredible job of showing us, as we engaged in this with almost 40 centers, emergency departments across Alberta, that they measured 2 things: topical anesthetic and for time to first analgesia for musculoskeletal injuries like sprains, strains, and fractures. And the topical anesthetic use increased from 11 to 30% over the province during that study, during the time that she implemented this quality improvement project. And the number of minutes to analgesia for children with fractures decreased from 60 to 28 minutes. So incredible, tangible results that made the lives of children better in Alberta. SCIP is now working with Commitment to Comfort in a collaboration to, one, support the rebranding of Commitment to Comfort. They're doing some updating of their documents that they have and extending their materials to make them even more usable by families. They're now expanding to Dynalife locations, which are our blood and lab facilities, blood taking and lab facilities within Northern Alberta, so that children, when they're going to get blood tests at a non-healthcare facility or non-hospital, have the same options available to them for pain management as they might within the Alberta Children's or the Stollery. And then planning a full-scale Commitment to Comfort spread across our local hospital and disseminating and sharing these resources across the province. So if this is interesting to you, please do reach out because these resources are available free of charge. So I'll round out and finish out with a few reflections briefly. First, to say, why then, when we know these things work and we know that children's pain matters, even short-term acute pain can have these long-term consequences, why don't we prioritize this? And I think some of it is that we still think of procedural pain in children as unavoidable consequence of medical care, and that's just not the case anymore. It is avoidable. We have many, many things we can do to make it avoidable. We hold on to a mistaken belief that the resultant pain is trivial, and that's just not true. N of 1, my own son, who had appendicitis, perforated appendicitis 3 years ago, when you ask him even now, 3 to 4 years later, what the worst part of that experience was, he will tell you it was the IV insertion. And that to me is a very profound reflection from a child who's gone through a painful condition. And we have a false reassurance because the long-term consequences of procedural pain are temporally distant from the acute experience, right? So if we have an error in a surgery, cutting the wrong vessel, we see right away what the implications are, for example. But when you allow a medical procedure to happen without appropriate interventions to minimize that pain, yes, the child looks upset in the moment, but we don't see the needle phobia, the healthcare avoidance, the drops in IQ, for instance, that I've alluded to before, because they're just temporally distant. So we have to make ourselves a little bit more aware of what we're doing. So my call to action to all of you is to alter our conceptualization of pain from an unavoidable consequence of medical procedures to a preventable adverse event. And I choose those words on purpose. If we do that, then we can use reporting and analysis tools. It's no longer an option within individual patient care plans. It's now expected. Of course, you were going to personalize it to the child, but now doing it is no longer an option. And it will also, most significantly, will make us consider untreated pain as an adverse event, which takes the accountability away from the individual patient, parent, or practitioner and puts it on a system so that we can do a better job as a healthcare system for these families. So in closing, untreated pain affects everyone. Managing pain and distress in children keeps people healthy throughout their entire lives. And I challenge you to be an advocate every day. Merci beaucoup. Thank you.